This conference will now be recorded.
Good afternoon, everyone. Am I audible to you?
Yes, sir.
Okay. Okay. See this case scenario. A patient named Uma, 15-year-old, known case of hepatitis C, presented with complaints of increased sweating, headache, and palpitations for 1 year. And she is a diagnosed case of hepatitis C and undergoing treatment for that. Recently, she was diagnosed to be hypertensive, but she is not taking any medicine. Ultrasound revealed a mass in the suprarenal area. Okay. This is the CT scan. You can see the suprarenal mass. Can you see here above the kidney? You can see one mass on the right side. Okay. Here also you can see. Are you able to appreciate it? Here. You can see the mass above the right side. Okay. Here also the mass with increased vascularity. Okay. So what is your diagnosis? A young female presenting with palpitations, headache, and hypertension. So what do you think of? Any idea? So it can be Pheochromocytoma. Okay, we'll see. This is the anatomy.
Adrenal adenoma.
Okay, I'll tell you. Okay, this is the anatomy of adrenal gland. Adrenal gland, as you know, it measures around 5 into 3 centimeters. This is all not needed for you. It is divided into cortex and medulla. Cortex is 85 and medulla is 15%. It is derived from the mesodermal cells of the adrenal cortex. Neuroectodermal cells migrate to the cortex from the neural crest during the embryogenesis to form the adrenal medulla. Okay. So cortex is formed from mesodermal cells and medulla is formed from the neuroectodermal cells. Okay. Neural crest cells also migrate to the para-aortic and paravertebral areas. So there is some cells will be migrating to the para-aortic and paravertebral areas. So, but most extra-adrenal neural tissue regresses by, but may persist at several sites. Okay. Usually these extra-adrenal neural tissue where the neural crest cells migrate, no, this para-aortic and paravertebral, they will disappear usually. But in some people, they may persist. Okay. So of these, the largest of the are located in the left of the aortic bifurcation near the inferior mesenteric artery origin, and it is designated as origin of Zuckerandl. Okay. As you have seen, some of the neural crest cells will be migrating to the para-aortic and paravertebral areas. What is a normal thing? They should disappear, but in some patients they may be persisting. Okay. So the largest of those is called organ of Zuckerandl. Where is it located? At the bifurcation of the aorta near inferior mesenteric artery origin. Okay. So adrenal medullary tissue also may be found in the neck. Urinary bladder, this is very rare. Okay. So already we know cortex, we discussed, divided into 3 layers: glomerulosa, fasciculata, and reticularis. And we know what hormones they will be secreting. Okay. So coming to medulla, it is derived from the neural crest cells. Okay. So up to 10 to 20% of the gland's volume is reddish brown in color. Okay. And produces catecholamines like epinephrine and norepinephrine. The cells are arranged in, this is all not needed. So they are called chromaffin cells because they stain specifically with chromium salt. Okay. That's why this tumor is called pheochromocytoma. Chroma means chroma. They are specifically stained with chromium salts. That's why they are called chromaffin cells. Okay. So what is the normal physiology here? The phenyl ethanolamine and methyl transferase. which converts the norepinephrine to epinephrine, is only present in the adrenal medulla and the organ of Zuckerandl. Okay, so whenever the tumor is arising from the adrenal medulla or organ of Zuckerandl, what will be increased? Epinephrine levels will be more than norepinephrine, because the enzyme needed to convert norepinephrine to epinephrine is present only in the medulla and organ of Zuckerandl. All other extra adrenal sites, this enzyme will be absent. So by looking at the levels of epinephrine and norepinephrine, we can understand from where it is originating. Okay, so the catecholamines are stored in granules called chromogranins. Okay. They are bound to the protein albumin. They are secreted by stimulation to various stress. So how they are cleared normally? Catecholamines are cleared by reuptake of the, at the sympathetic nerve endings there will be reuptake. Okay, and there will be peripheral inactivation by COMT, catecholamine O-methyl transferase and monoamine oxidase, and excretion by the kidneys. Okay, so these are produced by the adrenal medulla and organ of Zuckerandl, and they are cleared by reuptake and inactivation by enzymes like COMT, MAO, and excretion by kidneys. Okay, this is the normal physiology of the hormones, adrenal hormones. Okay, metabolism of the catecholamines take place in the liver and kidneys by the formation of metabolites such as, once these catecholamines are metabolized, the end products will be metanephrines, normetanephrines, and vinyl mandelic acid. Okay, which may undergo further glucuronidation and sulfation before being excreted in the urine. So these are the products that are ultimately produced from the metabolism of epinephrine and norepinephrine. Okay, so you have to remember metanephrines and normetanephrines. Okay, so the diseases of the adrenal glands can be classified into from the adrenal cortex and medulla. Cortex we already discussed, Cushing's adenoma, Conn's adenoma and all. Okay, Cushing's we already discussed, no? So the adrenal gland diseases coming from the adrenal medulla are pheochromocytoma, malignant pheochromocytoma, and neuroblastoma. Okay, so today we will be discussing in detail about pheochromocytoma. So it is a tumor arising from the chromaffin cells from the adrenal medulla. Already we discussed some extra adrenal sites also contain these cells. So they can also arise from extra adrenal chromaffin tissue like organ of Zuckerandl. Okay, these are the catecholamine secreting tumors. So pheochromocytomas were first identified by a scientist called Frankel in 1885, but the name was not given until 1912. A scientist named Pick named it as pheochromocytoma because he noticed that there is a chromaffin reaction of the tumor cells. Okay, that's why he named it pheochromocytoma. Okay, the first successful adrenalectomy for pheochromocytoma was performed by Rooks. So here you can see this is the adrenal gland. You can see once it is left, it underwent chromaffin reaction. You can see from fresh surface it turned into dark brown color. Okay. When this is immersed in potassium dichromate solution, this is the chromaffin reaction. Okay. So the prevalence is 0.1 to 0.6%. So out of 100 patients with hypertension, so only 0.1 to 0.6% patients will have pheochromocytoma. So it is a very rare cause of hypertension. Okay. Overall prevalence is very less, 0.05%. And 4% of the incidentalomas. What are incidentalomas? What are incidentalomas? Any idea? The name itself suggests, no?
Rare incidental findings.
Yeah. So whenever some patient comes with some other complaint, you do ultrasound and you find some adrenal mass. Those are called incidentalomas. Of these, 4% they will be pheochromocytoma. Okay. So which age group it will be common? It is common. It can occur at any age, but peak incidence will be 4th and 5th decade of life. So is it common in male or female? So it doesn't have any gender predilection. So it is equal in both the sexes. Okay. So there is a 10% rule in adrenal tumor, pheochromocytoma. What is it? 10% of them are bilateral, 10% are malignant, 10% occur in the pediatric patients, 10% are extraadrenal tumors, 10% are familial, 10% are not associated with hypertension. These are main important thing is 10% are bilateral, malignant, occur in pediatric and extraadrenal. Okay, familial also. So these are the 10% rules for pheochromocytoma. Okay. In surgery also you might have studied this topic. Is it finished in surgery? Pheochromocytoma?
Yes, sir.
Yes, sir. Okay. Okay, then we'll be revising only. So risk factors will be it occurs in families with MEN syndromes, MEN 2A and 2B. In 50% of the patients, they will have pheochromocytoma. Okay. So we already studied about MEN 1. What will be there, MEN 1? Triad of
Three
MEN 1
P's:
syndrome. What is it?
pituitary, hyperparathyroidism, and pancreatic tumors.
Yeah. Okay. So this pheochroma is common in MEN 2A and 2B. Okay. We'll discuss MEN syndromes again. And VHL, von Hippel-Lindau disease also can have this pheochromocytoma. And other things are neurofibromatosis type 1. NF1 also can have pheochromocytoma association. Okay. And familial paraganglioma and pheochromocytoma syndrome caused by mutations in the succinyl dehydrogenase family of genes. Okay, these genes mutations can cause pheochromocytoma, familial causes. Okay. So there is a class. How does the patient present to you? So there will be triad of headache, palpitations, and diaphoresis. Okay. So these three are the triad. Okay. Headache, palpitations, and diaphoresis. Okay. So out of these, commonest is headache. So symptoms of sympathetic overactivity such as anxiety, tremulousness, paresthesias, flushing. What is tremulousness?
Shaking of hands. I mean, tremors.
Yeah, tremors like tremors on. Weakness, pallor, blurred vision, chest pain, SOB, abdominal pain, all these can be non-specific. Okay. You have to remember the triad. Commonest will be headache. Okay. So all they will have symptoms of sympathetic overactivity because epinephrine and norepinephrine levels are increased. Okay. Symptoms can be incited by a range of stimuli, including exercise, micturition, and defecation. So you can see the table from Harrison. This is the clinical features associated with pheochromocytoma listed by frequency of occurrence. Okay. So the number one is headache. Second will be sweating, and then comes palpitations and tachycardia. Okay. So commonest three includes the triad of the pheochromocytoma. Okay. And the fourth one will be hypertension, anxiety, pallor, nausea, abdominal pain, weakness, weight loss, and paradoxical response to antihypertensive drugs, polyuria, polydipsia, constipation. So these are all symptoms related to the sympathetic overactivity. Okay. So out of the clinical signs, hypertension in 90%, already we have discussed in 10% rule. What is that? 10% of patients will not have hypertension. That means 90% of the patients with pheochromocytoma have hypertension. Okay. It can be either paroxysmal or continuous hypertension. So the most common clinical sign is increased blood pressure, that is hypertension. Okay. So it is these are the one of the few curable causes of hypertension because these tumors can be removed by surgery also. Okay. So these are the curable causes of hypertension. Hypertension related to this tumor may be paroxysmal with intervening normotension and sustained with paroxysms or sustained hypertension alone. Okay, so these patients can have either paroxysmal hypertension. That means whenever the patient is in anxiety, that time the blood pressure may go very high, and in normal periods it will be normal. Okay, so paroxysmal hypertension is feature of pheochromocytoma. So as an abdominal mass which is non-mobile, smooth, and does not move with respiration, this all you'll read in surgery now. So what are the complications? Whenever the adrenergic overactivity is there, what will happen? It can cause myocardial infarction and arrhythmias. Okay, and some patients may go into sudden death. Okay, they may precipitate the hypertensive encephalopathy and cerebral hemorrhage, and the patient can have panic attacks. These are the complications. Okay, so what are the differential diagnoses when a patient comes like that? It can be due to hyperthyroidism or anxiety patient or any cardiac conditions, carcinoids. Okay, these are the differential diagnosis of pheochromocytoma. So how do you investigate this patient? We have to do 24-hour urine samples for catecholamines and metabolites. Okay, because these also, it is not a continuous secretion, no, epinephrine and norepinephrine. It will depend on the anxiety levels and any stress levels are there. Depending on that, they will be secreted. So we cannot check the levels of epinephrine and norepinephrine. So we go ahead with 24-hour urine samples for catecholamines and metabolites. Okay, so we go with plasma metanephrine levels. You can do plasma metanephrine levels. Even though the production is not continuous, the metabolism will be increased when the catecholamines are increased. So when you do plasma metanephrine levels, the levels will be increased in patients with pheochromocytoma. You can also go with urinary metanephrines, which are highly sensitive and specific. Previously, we used to do urine VMA levels, but nowadays metanephrines are more sensitive. So we are not doing urinary VMA. Now we are going with urinary metanephrines. They are more sensitive than urinary VMA. Okay. So there are some false positives in VMA tests also. By ingestion of caffeine, raw fruits, or medication like methyl dopa before testing, it may result in false positive VMA. That's why nowadays we are not preferring urinary VMA levels. Okay. There is also fractionated urinary catecholamines, which are also very sensitive but less specific. Okay. Here you can see the sensitivity and specificity here. It's a table from Harrison. See, highest sensitivity is for 24-hour urinary metanephrine and plasma metanephrine also. So either of them you can go. Okay. Metanephrines have more specificity also. So urinary metanephrines will be more sensitive and specific. Okay. Imaging wise, you can go with CT or MRI. Both have equal sensitivity and equal specificity. Okay. So you need not do MRI alone or something like that. You can go ahead either with CT or MRI. And the other thing is MIBG scintigraphy. The sensitivity is less than CT or MRI, but specificity is more for MIBG. Okay. And other new diagnostic techniques like fluorodopa PET CT and all are coming. Okay. Just remember diagnostic tests are 24-hour urinary catecholamines and fractionated metanephrines. Fractionated metanephrines will be more sensitive and specific. So some drugs can cause false positive results like tricyclic antidepressants. Can you name any tricyclic antidepressant commonly used? Can you name one drug? TCA? You don't know one tricyclic antidepressant? Amitriptyline you might have heard of.
Yes, sir.
So many patients will be taking that, no? So they can have false positive results or MAOA inhibitors, levodopa, methyl dopa, labetalol. So you have to stop these drugs before going for urinary or plasma metanephrine levels, okay? Or illicit drugs like opioids, amphetamines, cocaine, ethanol, all these can cause false positive levels, okay? So you have to hold these drugs for 2 weeks before doing the test. And investigations include many physiological and pathological states can alter the levels of plasma catecholamines, so they are less accurate than the urinary tests. Already I told you. So both epinephrine and norepinephrine should be measured, as tumors often secrete one or the other hormone. Cutoff levels will be 2000 picogram per ml for norepinephrine and 200 picogram per ml for epinephrine. Okay. Clonidine is the agent that suppresses neurogenically mediated catecholamine excess, because some patients out of stress, if the patient is in hypoglycemia or any acute stress, then also these epinephrine and norepinephrine levels can increase. So to differentiate it, we can give clonidine. What will clonidine do? It is a central sympatholytic, no? Clonidine will suppress the release of catecholamines from the neurogenically mediated release will be blocked. So only the patients with pheochromocytoma will have increased production of catecholamines even after clonidine. Okay, the same thing only. So radiological scans are CTs are 85 to 95% sensitive and 70 to 100% specific. So where should we image? Image should include the region of the diaphragm to the aortic bifurcation, because some patients they will have organ of Zuckerandl. I told you, no, it will be present at the para-aortic region near the bifurcation at the origin of inferior mesenteric artery. So we have to cover that part also in CT scan. Okay. CT do not provide the functional information, but anatomically we can know where the tumor is. MRI scans are 95% sensitive and almost 100% specific. Okay. Here you can see MRI. Left side you can see this is a CT scan showing the tumor. This is the MRI image. You can see the pheochromocytoma of the left adrenal. So these are how the MIBG scan can be done, but nowadays we are not doing it. Here this is the how it looks in MIBG scan. Okay. Management will be, our important aspect is BP control. Okay. So how do we control BP? Here first we have to do alpha blockage, then only we can go with beta blockers. Don't give beta blockers. If you are giving beta blockers, what will happen? Alpha will be, what will happen? Alpha what it will cause? Alpha receptors on blood vessels, what will happen? Pharmacology is finished now for you.
Vasodilation.
Alpha is vasoconstriction, no? Beta is dilatation. Alpha is vasoconstriction. So if you give only beta blockers, what will happen? Alpha overactivity will happen. So the vessels will be more constricted. So what will happen? The hypertension will be shooting up. So never give beta blockers alone in patients with, whenever you are suspecting pheochroma, don't give metoprolol or retinol. You should not give. So young patients you avoid. Okay. So first you give alpha blockers if you are suspecting pheochromocytoma. Once sufficient alpha blockade is achieved, then you can go with beta blockers. Okay. So what is the drug of choice here? Phenoxybenjamin. It is also a important MCQ. So phenoxybenjamin is a preferred alpha blocker for the control of OP control of hypertension. So other alpha blockers are prazosin, terazosin, doxazosin. They also can be used. Okay. So phenoxybenjamin is a non-selective blocker of the alpha receptors. So what is the dose? 10 mg BD we can give, and we can increase 10 to 20 mg every third day. Okay. So what are the factors favoring phenoxybenjamin than prazosin and all is? It is a long-acting drug. So twice daily dosing will be enough, and it causes non-competitive blockade of alpha receptors. And it prevents the episodic surges of catecholamine releases during pre-operative and post-operative period. Okay. So there are some disadvantages like tachycardia, persistent post-op hypotension, and all can be there. Okay. So you just remember drug of choice is phenoxybenjamin. Other options already we discussed: prazosin, doxazosin, and terazosin also can be used. These are selective. Doxazosin and terazosin are selective alpha-1 blockers. Okay. Prazosin is not used because it is very short-acting drug. We have to give some 3 to 4 times per day. We have to give the dose. So adequate alpha blockade is indicated clinically by postural hypotension. So initially, when you give alpha blockade, the patient may complain of postural hypotension. That is common. Okay. And then the patient is advised liberal salt and fluid intake. It's called first dose effect. Whenever you are giving alpha blockade, the patient may complain of postural hypotension. Okay. Diuretic should not be used because the patient will be already fluid deficit. Okay. So you should not give diuretics. So target BP for pheochromocytoma is 120 by 80 mm of Hg in sitting position. Systolic BP and not diastolic will be 90 maximum. Okay. Once the adequate alpha blockade is achieved, beta blockers are started to control tachycardia because phenoxybenjamin, the side effect is tachycardia. No, to control it, we can use beta blockers then. Okay, pulse rate target is 60 to 80 per minute. Okay, so this is important point. Beta blockers are used only after giving adequate alpha blockage. So the ultimate cure will be
Sir,
by
please
surgical management.
explain the last point in the last slide. Last
Hmm.
point.
Yeah. So beta blockers are used only after adequate alpha blockade. Otherwise, what will, solid I told you know, alpha will cause vasoconstriction. So if you block the beta receptors, all the catecholamines will all act on the alpha receptors. So there will be hypertensive crisis. Okay. The patient comes to you with 140 by 90. You are giving beta blocker. The BP will go to 180, 190. That is called paradoxical response to antihypertensives. Okay.
Yes, sir.
Is it clear? Yeah.
Understood.
So if you are suspecting a patient is having, whether the patient is having pheochroma, never give beta blockers. That is the ultimate point you have to remember. Surgical management will be laparoscopic adrenalectomy. We can do robo-assisted adrenalectomy or open adrenalectomy. So that will be dealing with surgery, but intraoperative management is important. So during operation also, what will happen whenever we are removing adrenal glands, the catecholamines will be released into the blood circulation. That time the blood pressure may shoot up. So intraoperatively, how do we control the BP and what anesthetic drugs should be avoided? Okay, this is also important point. So there are some drugs which are to be avoided during anesthesia, like morphine, etracurium, atropine, pancuronium, succinylcholine. Should not give succinylcholine. Halothane. These are all MCQs you have to remember. Okay. These anesthetic drugs should be avoided in pheochroma patient. Okay. Drugs that can be used for safe induction are thiopentone, etomidate, and analgesics like fentanyl, alfentanil, and all. Okay. Inhalational agent like enflurane, isoflurane can be used. Muscle relaxants like vicuronium and procuronium can be used. Okay. So intraoperatively, hypertensive episodes should be managed by IV drugs. IV, what we can give? Phenoxybenjamin is oral drug. Okay. That is for OP management or pre-op management. Intraoperatively, whenever the patient is having a high BP, you cannot give oral drugs, no? Then you have to go for IV drugs. What are the IV drugs available? IV phentolamine, IV nitroprusside, IV nitroglycerin. So out of this, phentolamine is used, okay, mostly. or you can go with nitroprusside also. This is a drug of choice for intraoperative management of hypertension in pheochromocytoma. Okay. Temporary cessation of the surgical manipulation may be necessary. If the BP is not controlling, then we have to stop surgery. Okay. Short-acting beta blockers can be given, but we will not use the beta blockers. Okay. Aggressive fluid management with volume repletion. You have to give fluids. Okay. Because hypotension can occur as a result of sudden loss of tonic vasoconstriction. So what are the key points? Takeaway points are: avoid diuretics because the patient is already volume depleted, and don't restrict the salt because this is not essential hypertension. It is due to increased production of catecholamines. And avoid beta blockers alone, and achieve adequate preoperative heart rate and BP control. Okay. Fifth point will be achieve the volume status. We have to give sufficient IV fluids before surgery. And phenoxybenjamin should be stopped 48 hours before the surgery. Okay. You have to keep IV drugs like phentolamine, nitroprusside readily. Okay. Intraoperatively blood pressure is shooting up, then you have to go with IV drugs. So extraadrenal or bilateral pheochromocytoma, rule out multiple pheochromocytoma by functional imaging before going for surgery. You have to rule out other areas. Thank you. Any doubts?
Sir,
Hmm.
why can't we give alpha plus beta blocker orally?
We can give alpha plus beta, but you cannot tell. No, alpha blockers usually they will have a faster action. Beta blockers will have faster action. If you are going with the short acting beta blockers, esmolol or something you are giving, so if they will be acting faster than these alpha blockers, what will happen? When any first beta receptors are blocked, alpha will be available for the catecholamines to act. So there will be problem. Ultimately, we'll give alpha plus beta only, but first thing we have to give is alpha blocker. Once the alpha receptors are completely blocked, then only you have to give beta blockers. Understood? Huh? So
Okay.
final treatment will be alpha and beta both together, but we have to give first alpha and then beta. Once alpha is completely blocked, then only
And
you can
only
give.
intraoperatively
Intraoperatively,
only you said like lateral is given.
labetalol is also one choice. In emergencies, we can give because if no other drug is available, but drug of choice is phentolamine only. Intraoperatively, phentolamine or nitroprusside is available. You go for that drugs only. Okay. Labetalol is not preferred drug. That is one
Okay.
of the drugs. That's all. Ideal drug will be phentolamine. Okay.
Thank you.
Okay. Thank you.
Yes, sir.